Continue our discussion of ischemic heart disease, and now we take a look at acute coronary syndrome. What does that mean to you? It means that we are one step closer to having a myocardial infarction, but not completely. So with acute coronary syndrome, we understand that our patient has pain and may occur at rest. Now, before we get into any and all of this, just make sure that we understand some simple basic anatomy, because as we get to the tail end of our lecture series, I'll have you take a look at EKGs so that you know clearly the difference between what's known as a STEMI, an ST elevation myocardial infarction, versus a non-STEMI. Now, before we get to any of that, then we're going to build our pathology and our understanding so that you'll be able to clearly see this. Now, first, we have the aorta, but then we have the left coronary artery. Off the left coronary artery, that which is moving down between the ventricle. It will be a left anterior descending, as you should know from anatomy. That left anterior descending, if it underwent major massive atherosclerosis and had an area in which there was myocardial infarction, well, you have any idea as to what leads of your EKG that you might be paying attention to? It's important for you to understand, and we will when the time is right. But just to give you an idea, if it's the anterior two-thirds of the interventricular septum that the left anterior descending is supplying, and it's also supplying the lateral aspect of the heart a little bit, then what might you be thinking about? Well, the interventricular septum, you start thinking about things like V1 and V2 leads. Does that make sense to you? And then as you move towards the apex of the heart, and then you start thinking about V3 and V4, aren't you? I'm hoping that you have a pretty good idea as to what the leads of an EKG is going to be representing on the heart. And if you don't, that's quite all right, because we'll be paying attention to this as we move further. Now, acute coronary syndrome is what you're seeing here as a bracket. Before we get into acute coronary syndrome, which would be a combination of unstable angina, acute MI, and I cannot have you memorize this, it's a buildup of atherosclerosis. Let's go back to the concept of supply and demand, supply and demand. Do you remember that? With supply, what then happened? The coronary arteries underwent occlusion. And there was a progressive occlusion that was taking place that eventually resulted in pain in the chest, even at rest. And what about before that? Well, before that, it was stable angina. And you keep this out of the discussion of acute coronary syndrome. So, when you take a look at stable angina, who's your patient? Coronary arterial disease, atherosclerosis, head to toe. Remember, we talked about this with cardiovascular disease, including peripheral vascular disease, cerebrovascular accident, and our topic at hand, which is coronary arterial disease. Under stable angina, the precordial chest pain is exacerbated by either stress or exercise. Now, by stress, there are a couple ways that we could then induce this, can't we? What does that mean? Well, your patient, let's say it's a 67-year-old female, and she tells you, hey, doc, I'm having chest pain when I'm walking a few blocks or when I'm walking up the stairs. When I stop, the chest pain goes away. You do an EKG at rest, what happens? Everything comes back to normal. Do you say, bye-bye, have a nice day? No, my goodness. You want to stay in practice, right? And so therefore, you have to then induce a stress test. Now, if your patient has arthritis and it's debilitating, please don't be a masochist and put your patient on a treadmill. That's not very nice. Be nice to your patient. So we will get into what's known as your chemical stress test, because that is incredibly important. And what kind of changes would you expect to see in the EKG when you induce a stress? We'll talk about that coming up. Now, once this patient is giving you such a history, what do you want to give that patient automatically? You give this patient something in which there's going to be relief from the chest pain, correct? What does that mean to you? It means underneath the tongue, anytime that there's chest pain, you place nitroglycerin, correct? Sublingual. So when you place sublingual and it then dissolves and enters your circulation, what is it going to do to your veins? Good. Vasodilate. When you vasodilate your veins, what does that affect? Preload or afterload, please? Good. preload. You're going to decrease preload, and so therefore you're going to decrease demand, aren't you, of the heart for oxygen. That's exactly what you're going for. And then what about afterload? Well, it also causes arteriolar vasodilation. So when you have arteriolar vasodilation, you're going to decrease TPR. Let's move on. So now, with stable angina, what does this mean to you? What kind of changes? In the very beginning, we looked at the pathogenesis of an atherosclerotic plaque. Do you remember that? We talked about how there might be endothelial injury. We talked about how that was a thrombotic event. We also referred to your monocytes coming in and the smooth muscle cells that are being recruited from the intima coming into the media. And all of this is then forming a fibrous cap. And what happened in the middle? A necrotic core of LDL, foam cells and such. So, if that atherosclerotic plaque continues to build and build and build, what may then happen? 90% occlusion. We're moving towards what kind of angina? Oh boy, unstable angina. What does that mean to you? Hey doc, I'm having chest pain. When? Even at rest. Not good. Now this comes under what? This comes under the category of acute coronary syndrome. Is that clear? Is this a myocardial infarction? Not at all. Is that clear? Are you going to find elevated cardiac enzymes? What's your gold standard, please, for cardiac enzyme? You all should know troponin I. Not C. Is that clear? Troponin I. Are you going to find troponin I with unstable angina? Yes or no? Good. No. Is that clear? It is that crystal clear for you to differentiate between unstable angina, aka crescendo. What are you crescendoing towards? You're crescendoing towards leaving this planet. What does that mean? It means you're moving towards myocardial infarction. You don't want that. Is that clear? So another name for unstable angina, you'll never forget that, will you? Laugh a little bit. You must chuckle. So you have a crescendo. You're moving towards a myocardial infarction. How can you tell the difference? In myocardial infarction, obviously, the gold standard cardiac enzyme is troponin I. In unstable angina, yes, you're going to have chest pain at rest, but this is not a myocardial infarction, and you can confirm that how? Without finding any cardiac enzymes. Are you going to find changes on EKG? You could, and it's called a non-STEMI. All right, so we'll talk about this. So now, I want you to take a look at acute coronary syndrome. Are we clear about definitions? Are we clear about concepts? Can we now understand what's going on from the beginning of the lecture series up to where we are right now? It's all about building up this information so that you integrate across the board from biochemistry, physiopath, because that's what medicine is. And those are the type of questions, and those are the type of patients that you're going to, they're the type of patients that are walking through the door all the time. So, symptoms at rest. Number one, minimal exercise perhaps. May not be relieved by nitrates because it's really beyond the point of that type of therapy. Classified based on ECG changes. Now, it could be STEMI or non-STEMI. If it's non-STEMI, we'll talk about that being perhaps an ST depression. A STEMI is ST, elevation, myocardial infarction. And we will get into further detail, not to worry at this point. Next, the distinction, this is essential for management, is reperfusion therapy or not, is dependent on whether or not your patient has STEMI. Now, reperfusion is another topic that we'll have to go into further detail when the time is right. This is all under acute coronary syndrome. I'm going to keep repeating that so that you clearly know where we are. What's your mainstay treatment? Okay, now, so you have a clot. That clot is rather large, 90% perhaps. Let's do antiplatelet therapy. Let's do anticoagulants. Let's do maybe the drugs aren't working properly, and you have to get in there percutaneous. And you have to get in there with what's known as angioplasty. What's angioplasty mean? That type of intervention, percutaneous type of intervention, angioplasty is ballooning, isn't it? Maybe you place a stent. Maybe, just maybe, in that cath lab, your cardiologist is not able to get in there and put in a stent, which your only step of management at this point. Next step of management, CABG, coronary artery bypass surgery. Let's continue. Now, if it is STEMI, ST elevation myocardial infarction, what do? Fibrinolysis, what does that mean to you? You have your reperfusion type of issues that we'll talk about. Don't worry, that is something we have to discuss in greater detail. Next, acute coronary syndrome, myocardial infarction. What are the complications that you're worried about post-MI? Well, the number one complication, you're worried about arrhythmias, aren't you? And so therefore, you want to try to give your patient antiarrhythmics. Now, post-MI, let it be your boards. Now, clinically might be a little bit different, but remember, antiarrhythmics are quite a complicated topic, isn't it? Now, we will deal with a little bit, and right now, your first introduction, post-MI arrhythmia, your best drug to give is something like your class 1B drug. B for best. In general, when you say class 1 antiarrhythmic, then what channel are you blocking, please? Sodium channel. Good. What kind of sodium channel? Voltage gated or ligand gated? How important is that? Really important from physio. It's your voltage gated sodium channel. Is that clear? This is something that you will be talking about and have discussed in pharmacology. All I'm doing is reiterating it, and you clearly see where to bring all this information into play. Next, beta blockers, perhaps. Post-MI, think about metoprolol. Antiplatelet therapy drugs such as statins and so forth. Also, what else are you worried about with myocardial infarction and as being a complication? How about congestive heart failure? If it is congestive heart failure, then you do everything in your power to decrease the mortality, increase survival. And those are the type of drugs that you're looking for, aren't you? So therefore, those include spironolactone, metoprolol. You're also looking at drugs such as ACE inhibitors. Now, mainstay of treatment eventually is the fact that you're trying to decrease the demand of oxygen by the heart. You're trying to increase the supply of oxygen continuously, nitrates perhaps, and eventually, once you get past the hurdle and the emergency has been properly managed, then you get into lifestyle modification. Is your patient obese? Is your patient a smoker? Those things that you cannot control, but you must educate your patient with, include the fact that you have familial issues. The beautiful, beautiful slide, the beautiful little explanation, a table in which it gives you a storyline between stable angina moving into myocardial infarction, and we will get into further detail as we move through here.